Well, welcome everyone. Thank you so much for joining our webinar today. I'm going to be talking to you about strategic implications of COVID. So how do you deliver the right care, support your physicians, and really further strategic objectives as you're dealing with the COVID crisis, so that we basically can leverage some of the COVID requirements as foundation for your future. My name's Alan Miller with Cope Health Solutions, and I'll be facilitating today. And I'm going to walk you through a bit of introduction and then hand off to my colleagues. I'd like to introduce, we're very lucky to have a great group of folks on here. So Dr. Andy Snyder, who is actually our firm's Chief Medical Officer at Cope Health Solutions. Andy has deep experience nationally. He has actually run IPAs in California. He has been at academic medical centers running clinically integrated networks. A lot of work around physician compensation, physician alignment, and again, a lot of work around everything from full risk, what they call restricted non-schemes in California, to fee-for-service with upside and quality, more on the kind of the Northeast model. We have Margaret Peterson, who is an executive consultant with Cope Health Solutions, an exemplary hospital CEO, has managed hospitals and health systems, has actually done a lot of work with hospitals that are taking facility risk, that understand that they need to be able to manage patients and members when they're out of the hospital, and has been very successful with that, doing a lot of work with medical groups and IPAs aligned with her hospitals. And Margaret's also been a great leader in the field and is currently past chair of the Hospital Association of Southern California, and is working with them on some of the work they're doing around COVID now. And we've got our partners at the law firm HMBR, which we're really pleased to have with us today. John Marin is a founding partner at Hogan, Marin, Babbo & Rose. He has 10 years of experience in healthcare, both clinical and administrative, actually inside health systems, more than 35 years experience in healthcare and general corporate and transactional law. He's actually been a great partner again for our firm, and Andy in previous roles, generally one of the national experts on CINs, clinical integration, ACOs, anything around how hospitals and physicians align, or hospitals to hospital alignment. John's been a great expert and a leader in that field. And his colleague, Tom Babbo, very similarly, 20 years of experience in healthcare. And again, Tom really has a deep focus and experience around value-based payment, physician-hospital alignment and collaboration, managed care arrangements. Again, between him and John, they've formed more CINs nationally than almost anyone else, with a number of ACOs. So we're very, very pleased to have them with us today and have you all get to hear from them. So a little bit of housekeeping. There is a way to enter questions through the Q&A feature in Zoom. And what we're going to do is we're going to track your questions, whether you enter them there or whether you email them to info@copehealthsolutions.com. We will be tracking your questions, and we will provide you a written Q&A after the webinar. We may be able to answer some during the webinar today. So brief overview of the agenda. We're going to have Margaret and Andy talk through how health systems can deliver the right care and support doctors, more important than ever, always has been. And Tom and John are going to walk through some of the collaborative necessities of COVID, and then how to implement a clinical integration strategy. And then we'll wrap up and do Q&A. So with no further ado, I'm going to hand it over to Margaret.
Good morning, everyone. Welcome to this webinar. What I want you to do is to take just a second to think about how we run our organizations. And what we tend to do, though, as hospitals and other healthcare providers, is that we limit ourselves into this box of regulations. And we don't often think about the creative things that we could work together on as healthcare providers. Well, folks, today we are fortunate to be in the most unusual of times. And what we as COPE and HMBR, our legal partners, are going to do today is give you a few ideas from what we are seeing with our clients and how we are helping our clients navigate through these most opportune times. Now, there are two ways we're asking our clients to look forward as hospitals and healthcare systems. Let's figure out first what we're going to do with the dollars that are out there for this crisis today. And then let's also look forward to how we're going to look at not only the current solutions, but use those current solutions for lasting solutions and lasting relationships. So we want to be able to prioritize today, but also be able to leverage the opportunities that we have. Now, we've taken a very old word called collaborate and used that throughout our presentation. And you may be wondering, why do we go back to something that kind of puts us back several years? But collaborate is really easy to understand. It's easy to look at what the outcomes will be. And there's nothing better than the excitement and fulfillment and reward that comes from a community of healthcare providers working together for their patients and their communities. The question is, how can we, as health systems, deliver the right care and support physicians? And we'll go through some of the suggestions that we have as COPE and HMBR, our legal partners. Now, some of the first things that we want to do is take a look at the CARES Act. We've heard about the $2.2 trillion that's out there, and we want to be able to look at the components that are under the CARES Act. There are two components, the mandatory spending and emergency funding, and we're going to talk a little bit more detail in relation to those dollars. Now, one of the things that we want to be aware of is that things are changing every single day. Just this morning, there was another notice that said that funding for testing sites are going to be eliminated pretty soon. Now, there's probably going to be quite a bit of backlash, and we'll keep an eye on it to see what happens to that. The other thing that's also happening just this morning is that there is a proposal from the Senate Republicans to add another $250 billion to the Paycheck Protection Act. And there's also political conflict in that the Democrats are looking at trying to add another $100 billion to hospitals, another $150 billion to state and local governments, and another 15% increase to the nutritional assistance funds. So we've got to keep an eye on also what's happening currently in the market so that we don't lose out on what is happening. But what this also will tell you is that we've got to move quickly. Now, we believe that it's absolutely important to take advantage of this time where we're being forced to take a look at how do we deliver care within a network and using remote care models. And so we'll talk a little bit about that also. Now, increase in collaboration. This is the most unusual of times because just like everything else in our lives around us, we get very involved in what we're doing. It becomes a very competitive environment. But what we want to promote is a pro-competitive environment, which means promoting a competitive environment for the greater good, for making sure that we get the very best care to our patients and resulting in healthier communities. Let's talk a little bit about how we're going to access our funds through the CARES Act. Now, there's a lot of information out there, and this is where the experience of our clients comes into benefit to the overall healthcare community. Right now, we know that there's $2.2 trillion out there in two buckets, the mandatory bucket and the emergency funding bucket. Now, depending on where you are and the kind of organization you are, you're going to have different amounts of money available to you. Under the mandatory, there's a payroll tax credit, there's a small business assistance, and that's for employers that have less than 500 employees. There's also unemployment insurance. There's also the Marshall Plan for healthcare systems, and there's grants available there. There's physician fees available. Now, under the emergency funding, there's $100 billion available to physicians and health systems for unreimbursed or lost revenues. Now, those are two very specific categories that you can begin to document where you're losing money from lost revenues and where you're losing money from unreimbursed dollars. There's also $185 million available for rural critical access hospitals and healthcare providers, tribal health, and emergency telehealth funding. There's also another $45 billion available through FEMA for emergency response and also PPE and anything that's not paid by someone else. Now, what we want to make sure you understand under the FEMA funding is that duplication of funding is not acceptable. And so you want to be able to look at all your other resources that are available first and then look to FEMA for any additional funding. Now, one of the surprising things that we heard yesterday is that $45 billion have already been sent out or approved under the Accelerated Payments Program. Now, just to give you an example of how meaningful this is is that in the past, this process would take anywhere from 3 to 4 weeks, but this happened in 4 to 6 days. Now, 25,000 requests came in, and out of those, 17,000 were approved. Now, just to give you an idea of what happened prior to all of this, is that in the past 5 years, only 100 requests have been approved. So you can see what's happening is that there is an urgency from within the government to make sure we get the funding out, but what that means is that we have to be ready. Now, there's also been $90 billion in small business assistance loans that have already been approved. So we're starting to hear some good things happening. We are hearing of folks that have been receiving money. So this is real. This isn't something that is just out there in the news that we hear about. Now, if you're eligible, you want to make sure that you get your application in order. There isn't an application out at this point, but what that means is that we have to work on making sure that we have our documentation in line, that we're able to understand what our expenses are, what are we going to get reimbursed for, so we know what we're not going to get reimbursed for, and we want to make sure that you involve your entire organization. Don't limit yourselves to just who you think the CFO is and who you think is going to be able to get the money out or understand where the money is being lost. Involve everybody in your organization so that you can capture everything that is a possibility. Now, the distribution is going to be on first-come, first-served basis, so you want to make sure that you're ready and that you're able to respond as quickly as possible. So let's take a look at an example of how we can use this. Now, we're just going to give you an example of how you can use the CARES funding. And so we've set out a process that may work for you. It may not work for you, but it's an idea that we have out here for our clients. The first item is selecting what your priorities are. And it depends on the type of organization you are and the type of community you have. Some communities may only have one hospital, one long-term care facility, may not even have a behavioral health program, may have a home health agency. You may be an urban setting where you have a little bit of everything, so you have to take some time to figure out what is your market share. Or you may be a metropolitan area, and you may want to widen that circle depending on where your patients are coming from. Second, you want to be able to identify who your key health providers are. Physicians, hospitals, long-term acute care facilities, home health agencies, could be a nursing home. But you also want to make sure that whoever your local public health agency or your local community government agency is, to make sure that you involve them. Because I want to emphasize that when you get into a crisis or an emergency, you want to make sure that you know who your police contacts are, who your fire department contacts are. You may already have an emergency management center that you want to make sure that you interact with and that you can use their resources that are available to them. So don't forget about your public health agencies and the other sources of support that you have available in your community. You may even have informal neighborhood groups that you want to make sure that you connect with, because these folks have a lot of informal power that you want to be able to take advantage of. Next, you want to bring these folks together. Now, obviously right now we can't all get together in a room, but we can use remote capabilities, teleconferencing, and whatever Skype possibilities you may have available to you, and identify at least 1 to 3 priorities that are important to your community. Next, you want to take some time to develop strategies and tactics. What you have to make sure that you have, though, are strict timelines with disciplined execution of your strategies. Because at the end of the day, all of this working together is not worth anything if you can't come together and actually make things happen. Now, I'm going to walk you through an example here that may be meaningful to you, but you may have other priorities, but this is just a quick example. The priority would be Epidemic and Pandemic Preparedness Collaborative. Our source of funding would be the CARES Act, the Emergency Supplemental Appropriations. There's approximately $330 to $350 billion available in this bucket. However, to look more specifically, we can look at the $100 billion that's out there for health systems, or the $45 billion that's out there with FEMA funding. You want to create a task force of representatives from key entities, but you want to make sure that this doesn't become so large a group that it's not manageable. Now, again, don't forget your public health agencies, because they are going to be absolutely critical when it comes to an emergency such as this. Our goal will be to develop a center for the determined market that will have an inventory of supplies and equipment for emergencies. Now, you will have to set this up in such a way, and it can be set up under the umbrella of a particular provider that's already in your community, or it could be something separate that everybody has access to and ability to be able to use. Now, there are lots of other priorities that you can take a look at. There are difficult to discharge patients where your utilization management staff can link with home health, with LTACs, long-term acute care facilities, nursing homes, recuperative care centers, if you have them in your community, certainly behavioral health agencies, and lots of other providers in the market. That's one way that you can also develop another priority. Now, the other is also possibly identifying your patients that come to the ER, where you can set up a navigator in the ER 24/7. You could set up a link with all of your federally qualified healthcare facilities in the market, your medical groups, your solo physicians, because you want to know when your patients are coming to the ER and have the ability to be able to access their medical record. So these are just a few examples that are priorities that you may be able to utilize. Now, what we're trying to help you take a look at is, as COPE and HMBR, is that we not only want you to be able to figure out how to utilize the funding for today, but we also want you to be able to leverage that as long-term solutions for the future. And as communities, some communities, out of necessity, have learned how to work together. However, most of us have not really taken time to figure out how can we link with others where we are going to be able to maximize the resources that we have. Now, in this emergency, we've kind of been all thrown together. So the question is, how can we continue to look at our relationships that we're building during this crisis that will help us for the future? So I'm going to turn the time over next to Dr. Snyder. Andrew, take it away.
Thank you, Margaret. Next slide. Hello, everyone. So as we think about launching or expanding remote care models, I'm struck by how easy and how often we now just FaceTime or Skype or Zoom with our friends and family and other loved ones. I think also perhaps it makes me think about and be a little surprised at how little telehealth and remote care actually happens. The overall adoption is still quite low. I think, to be fair, it takes time for the technology and the platforms to mature, for the regulations to come into place, for the connectivity, for reimbursement and contracting to be able to all come together. So that convergence took some time. But I think, we're at a different place now. That pace of change, has thus far been quite slow overall, but that's because it's been based on sort of a convenience model of care. That telehealth would be cool and fun and good for people who use iPhones a lot and easy for some. But I think COVID-19 has proven it to be a widespread necessity. I think it's changed on a dime. I think staying remote, even in healthcare now, just means more for some patients. And in that sense, the patient with their family and their care providers at home are as important as any professional care connections are. They need to be connected to family and friends as much as they are to our social work care managers, primary care docs, pharmacists, specialists alike. But most deployed models to date currently remain more constrained in how they're deployed as a closed platform of communication. The engagement of the family and the caregivers cannot be underestimated. I think this specific period we're in now of isolation has shown that acutely. More and more, the family are going to be essential parts of our scalable care across our communities. So this being done at home, connecting to the professionals when needed at the top of the license is a newer paradigm that's going to scale rapidly. home care management and other remote care models, such as pharmacy help, behavioral health, chronic care models, and others, to deploy those at scale across all providers and care team require really a complex implementation across staff with expertise, technology and communication platforms, infrastructure and support, and all the documentation that goes with that. So that's, I think, acutely what's changed almost overnight. There are, as Margaret was indicating, grants available. There's the Marshall Plan for grants, and there's other funding, as she was indicating, as well as things through HRSA, the $185 million just for telehealth programs. So I think this moment is a time that we can seize upon and use the funding for the acute crisis that will actually serve us well in the long term in new models of care as they will burgeon coming out of this. So what does this mean for the networks and physician solvency out there? I think another thing this COVID-19 crisis is proving is an extremely difficult time for all providers. Employed and contracted providers are under terrible strain as systems are strained due to this crisis and resources. Most certainly, the independents and groups are also equally strained, if not more. They likely do not have the current infrastructure nor the capital to deploy a remote care model widely or efficiently. Certainly not efficiently enough to remain viable and sustainable during this single pandemic. So I think that's a frailty of our system being exposed. Perhaps even after all this is done, networks, there'll be enough unfortunate people not working, including in the healthcare arena, that networks will need to change and will need to be reevaluated for adequacy and just access. So in the immediate, there's employed and contracted physicians can be redeployed and used in crises like these. That's a little bit more straightforward. But independents also, they need to be supported and paid during this time and can be quite useful during this time as locum tenens, as telehealth staffing, as a triage center staffing, for testing and outreach staffing. There's ways to pay them for that, keep them in business. And in fact, as we're with the telehealth discussion, provide them even a platform to run their business. This collaborative and supporting community physicians now, perhaps even more now than ever, can certainly have long-lasting benefits after this crisis recedes a bit. So on that note, speaking more towards the long term, I'm going to hand it over to Tom Babbo and John Marin from Hogan, Marin, Babbo, and Rose out of Chicago.
Thank you, Andrew. This is John Marin, and go back to that slide, the previous slide, please. We're going to drill down a little bit. What Tom and I are going to thank you for being here. Thank you for hearing us. Thank you for participating in this effort. So what we're talking about is the things that we've faced over the last few weeks with clients, and that is those, and Andrew's right, employed, independent, contracted, and medical groups. What can you do today? What can you do short of deploying them? If you can deploy them, that's all good too. But what we're going to talk about is some of the regulatory relaxation that's occurred and some of the common sense things that we've seen. What some people are doing with their employed physicians is to actually have them not worried about their productivity at this point in time, and to reassign them to other kind of COVID-related duties, and make sure that they understand. What Margaret said is you got to focus on your key providers, and your key providers are obviously physicians. And people were worried. What about Stark? What about anti-kickback? And we'll get into that, but there's been a lot of relaxation. There are independent contractors, and so we've had questions. I know I can roll out telehealth to my employed physicians, but can I do it for my independents? Well, the answer to that is, as you're going to see and understand why, is yes, and you must. We have to have a way, and you need to think about it this from our perspective. You're not doing something for the doctor. You're not giving something to the doctor. What you're doing is providing patients with greater access in a very terrible time. You've got people that are COVID. You've got people that are not COVID but need other kinds of care. The same issue is with contracted and with medical groups that you deal with. It's the same kind of mindset. The mindset is I have to keep these people going. I have to support them in any way I possibly can. what we talk about with people is how do we focus these efforts, and how do we put the narrative around them, so at some point in time, if anybody ever asked a question, but the answer is you can do it. And Tom is going to get into a little bit about why and how and what's going on now on the next slide.
Hi, everybody. Tom Babbo here. So what we've found over the last few weeks, and we've been tracking this very closely and talking with a lot of our clients around the country in terms of sort of the struggles that they're facing. As John and Andrew mentioned, there's a lot of doctors out in the community and employed physicians are feeling very vulnerable with severe drops in their volume, while the health systems that they work with are ramping up their response for COVID-19. They're seeing procedures drop off, visits drop off, and really looking at an economic future, whether they're employed by a health system or a large medical group, or out just physicians who have been working independently out in the community. And so what we're seeing is really an opportunity right now that we've never seen before from a regulatory and legal standpoint to pursue these local and regional collaborations with physicians and even with other health systems in your community. And that would include physicians or hospitals that are in the same geographic area and those across a region. What we found were basically two big areas. One is that we see in this over the last week and a half, 2 weeks, we've seen a lot of pronouncements and guidance coming out of Washington around the existing regulatory framework. Now, we know, because we've helped a lot of clients to pursue these things, we know that a lot of hospitals and health systems have already implemented legal vehicles, whether they are clinical integration networks or co-management programs or accountable care organizations, PHOs, IPAs, and whatnot, through which they can legitimately provide physicians payments and incentives. They're already structured in accordance with existing federal Medicare, Medicaid fraud and abuse laws, regulations like, under the Stark Law or the Anti-Kickback Statute, Civil Monetary Penalties Act. All these models that a lot of you have already developed take into consideration of federal tax exemption rules. They abide by federal antitrust enforcement policy. But what we've seen is that federal agencies, Department of Justice, Health and Human Services, Federal Trade Commission, exhibiting a real uncharacteristic openness to set aside what could have been a rigid regulatory interpretation to accelerate the ability of hospitals and doctors to respond to these kind of healthcare needs that are related to COVID-19. And there's a continued necessity of delivering crucial healthcare services in the community. So you really need to, and especially when they're diverted to a coronavirus response. So for instance, last week, CMS announced blanket waivers from the Stark Law, something we've never seen before. It makes sense in this type of a crisis, but they're relaxing the Stark Law around what they're calling COVID-19 purposes. And those include the diagnosis and of medically necessary treatment of COVID-19, securing services of physicians, ensuring the ability of healthcare providers to address patient and community needs due to the COVID-19 outbreak, expanding capacity for healthcare providers, shifting diagnosis and care of patients to alternative settings and appropriate settings, and addressing, and then we thought this was really interesting, not only recognizing that you have to provide that COVID-19 care when you see it peaking, preparing for that COVID-19 care and making sure that you can engage physicians, incentivize them to participate, but also addressing practice and business interruption due to COVID-19. So those are all defined as what they call, CMS defined all those as quote unquote COVID-19 purposes. And what we thought was fascinating is that these blanket waivers apply even to above fair market value payments by hospitals and health systems to physicians and other healthcare providers. Then you can, when you recalibrate these existing models and use these blanket waivers, you can then also look to the fact that the Federal Trade Commission and the Department of Justice, only a few days before CMS and talked about these blanket waivers, indicated that they feel, and they wanted to tell the healthcare industry that they understand that responding to COVID-19, a very unique crisis, would require otherwise competing hospitals, physicians, medical groups, other providers to really collaborate in an innovative way to try to address this in ways that people may not have considered a possibility before. The blanket stark waivers combined with sort of looking at a collaboration in your community and perhaps across your region allows you to create sort of a intermeshed safety net with other health systems. Now, it addresses, and we'll talk about this, and John will pick it up after I speak, but we see that this has both sort of this immediate crucial response to specific COVID-19 preparations if you haven't seen the peak cases yet, so you're preparing for that, or you're in the midst of trying to rationalize services amongst a community. We're seeing a lot of innovation being done internally within individual health systems. We're seeing some government, state government, local governments trying to coordinate the response. But there's really no need, given this new regulatory environment, there's no need to wait to pursue collaborations with each other and do it in a way that you can feel confident will help you to respond right now to the crisis, but also with a sense, every health system has its own strategic needs and can't put those, forever on hold because the crisis will pass. And when it does pass, we have to respond to what the environment looks like post-crisis, and doing it in a way where you can create sort of a sustainable model of sort of sustainable joint venture collaborations with other hospitals and health systems within your community to address future crises and future business and other clinical needs.
And thanks, Tom. This is we're going to now move into a different phase and talk a little bit or a lot about immediate advantages and what you can do through collaboration. You can in your own community, in your own thought, figure out maybe additional things, but these are some of the things that we've encountered in the last few weeks and recommended in the last few weeks. As Tom mentioned, CMS and FTC have given a broad berth to collaboration. And the DOJ, wait for this, has introduced a 7-day review process, something that used to take a year or two to get reviewed. Now they'll review in 7 days. Tom and I actually talked to a long-term FTC attorney and just to validate what we saw, and he was absolutely 100% behind it. In other words, you got to think about why they're doing this. They're doing this because they want you to act immediately. Okay. Other things we've done. If you're one hospital approaching a payer, a non-governmental payer, and asking for prepayment, you're less likely to get anywhere. If you're 10 systems working together or 3 systems or whatever number, and you're going to the Anthems, the whoever of the world, and you're saying, look, I need you to accelerate advanced prospective payments to my doctors and to my institution, you might have a chance, or you've got a lot more leverage. Focusing on something that should happen even without COVID is academic medical centers interacting with community hospitals to begin to rationalize care. In this case, if you go to if you move over, what we're talking about is things like cohorting patients. And those, because we have a lot of clients in New York and in Boston, and what they're talking about is, what do I do with PUIs, people under investigation, who may or may not have COVID, but the test takes so long that we don't know what to do. What do I do with the people who have COVID and are not super sick? Can we have to make decisions about whether or not they can go home, they need to go to someplace else or stay in our facility. And these can become community decisions, okay? So that we as a community are treating all these patients the same way. It's going to have a long-term impact on healthcare. What do I do with the patients who absolutely have to be admitted and are not near crashing or crashing? What do I do with the people that are crashing? How do I deal with that situation? How do I designate specific hospitals for post-discharge COVID patients? Some COVID patients perhaps can go home, some cannot. Some need ongoing care. Where are you going to send them? You can't send them to a nursing home. It'd be manslaughter at best. So getting together and working as a community and looking at some of the opportunities, coordination between community employed physicians, as we've referred throughout this discussion about rapid access and deployment of COVID testing, exchanging supplies, working with other people to make sure testing is available and sites are well identified and people know what to do. People in your community, if they have heard a lot on TV about what the symptoms are. What if I start feeling like I might have symptoms? Am I going to be able to, is there one place I can go to, or two or three or whatever number, to be able to talk to somebody to understand and make a telehealth assessment of me? Coordinating transportation across facilities, among facilities, making sure patients can get from one place to the next without being out in public. And there's more. Compiling, over a period of time, working together with multiple systems to compile protective gear and supplies, and look at local manufacturers and have a tie-in. In other words, it's things you'd have to do on your own, but now you're working together in a collaborative fashion relative to what needs to be done.
And I think if we just linger here for a second, what this means is you don't need to wait for local government, state government, the federal government to sort of coalesce and sort of organize this process. The health systems today, again, are doing a lot of really innovative things within their own four walls, or within the four walls of their multiple institutions. But how much more powerful would that be if they're doing it together? How much would it be to also free up the certain facilities, certain ORs for procedures that aren't COVID-19 related, but they're procedures that whether they're elective or otherwise, could be taking place, probably should be taking place today, that have been either postponed or are prevented, or are being done in a way where there's a lot of mixing and danger of infection or cross-infection. Why not set up a coordinated way of trying to bring a lot of the demand for those services that's remaining out there and people staying home today, bringing that into your facilities and starting to get those procedures back on track.
And I think that the point of waiting for the government to do something is critical, because the government's done as much as it can. The government is, as Margaret mentioned, making rapid access to cash available to providers and suppliers. The government is putting out warnings and telling people to shelter in place. The government is waiving some of these legal requirements that might have stopped you before, particularly Stark and anti-kickback and antitrust. But it's now time but the government can't really do any more than that.
When you set up these collaboratives, as the FTC and DOJ are encouraging to accessing the current CMS blanket waivers, which we know won't last forever because they are COVID-19 related. But how do you do that in a way that's going to also serve your future needs? There's a lot of hospitals and health systems know that that there needs to be an interplay between local community hospitals and large tertiary, quaternary, academic type medical centers. Physicians in the community need to work in a collaborative way with large medical group and employed physicians. If you build these joint venture collaboratives around COVID-19, that really creates a framework that can last, where you can have the health systems that sort of make sense to come together and start working on these things together, can create an organization an organizational framework where they can have a forum where they can continue to meet to talk about the healthcare needs within the community, talk about real rationalization of healthcare services, talk about how to provide the proper care in the proper setting, that where the care that should and can be provided in local communities stays there, but when it needs to go to a much more acute or complex setting, it can go there and then get brought back to the community in a smooth fashion. So by doing this, you can now, around COVID-19, this crisis, you can really look at it as also a way of trying out and sort of practicing collaboration with each other in ways that, if for situations where there's been a lot of merger activity in the healthcare industry. There's been a lot of acquisitions in the healthcare industry around hospitals and physician practices. This provides a different and new model around that really focuses on the healthcare of populations.
And we began this process prior to COVID-19 and have been working with different institutions to integrate service lines and to do things together. And there was a lawful way to do it then, and there's a lawful way to do it now with a lot more flexibility, and with plus the ability to have somebody, the FTC, take a quick look at what you're doing and give you some guidance if you want. And so this is a very sustainable platform that you need to think about in terms of your community. People in healthcare talk a lot about population health, and this is real population health management. It's getting a network together of institutions in a given community or adjacent communities, and getting them to work together around quality and efficiency and the best site of care. So it is a dramatic, immediate necessity now, but it's also a long-term strategy.
Right, exactly. When is it more needed but now? But all these same issues that we're seeing as necessary during COVID-19, those are enduring problems.
Thank you so much, everyone. I'm going to work to wrap this up and kind of bring it home. I know a lot of the folks on the phone, I actually personally appreciate you all calling in, and a lot of you are either with health systems or medical groups or FQHCs, and hopefully this has been helpful for you to help you understand the following. There is an opportunity right now to do a lot of the stuff that many of us on this call have been talking about trying to do for a long time. Like what? Like organizing physicians and really helping to support independent doctors in the community in a way that we couldn't before, but specifically if we didn't have capitation or global risk agreements that gave us some of that umbrella protection. So what's really exciting right now for me personally, what I would ask folks to think about is, in your community today, your doctors are suffering. I know you know this, but it's a reminder. And if you are a doctor or a medical group, you know this is happening. As much as the hospitals are suffering and stressed, the doctors in the community are truly, truly small businesses and suffering. Health systems and hospitals, large medical groups and others have an opportunity to support these doctors. I was actually emailing with another colleague. There's certain parts of the country where they've been trying so hard to find a way to bring these doctors in the community together and really create a network, because there's not the commercial population that folks usually use to launch a CIN. There's not the rich tradition of risk. These doctors are going to need help right now. Let's get out there and help them. You know, the telemedicine and remote care managing is the new EMR. We can set folks up on a platform. We can create common workflows and clinical guidelines that are going to add massive value to the community and align these doctors in the long run with you in these medical groups and FQHCs. What do we need to do? We need to create a value proposition. What is our value proposition to you, the doctors, the FQHCs in the community? How are we going to help you today? How is this going to help you in the long run? They're, of course, they're dying of thirst right now, right? Give me some water. But at the same time, they're very smart, and they're going to want to know that there's a foundation under here and some thinking for the long run. So we need to provide a concrete, clear, easy to understand value proposition that says, doctor, here's how we're going to help you today. This is what we're going to do to leverage your talent and support you and keep your practice open or offer you other opportunities within our network. And this is what it's going to mean for you in the long run. Same thing with hospital to hospital for some of the smaller hospitals that are struggling. And you also have opportunities here. You're going to be managing more people from home. Guess who does that? Home health. What is your engagement with home health like? Can you help them with a platform that does home monitoring? Get them engaged again with your workflows, your clinical guidelines, so they become a deep part of your network, an extension of you, the health system, hospital, or medical group. And finally, the same thing with skilled nursing. And many of us have talked about the fact that you need a narrow skilled nursing network, and some of them need to be subacutes. We shouldn't be managing these people in the hospital, but we've got to have the capabilities in the nursing home to do so. Now's the time to do it. You've got a lot of regulatory relief. Everyone's tight financially, but there is money coming down the pike. And so I think the bottom line is this is a call to action for all of you. There's an opportunity here to engage in activities that will help your community in the short term with COVID maintain your physicians and not lose their businesses, not force more people into retirement because they just don't know how to survive and thrive. And at the same time, build your foundation for the future, because 3, 6 months from now, a month from now, whenever it is, there will be a Medicare Advantage bid process again. There will be reprocurements. There will be employers wanting to have commercial insurance on the market. The plans are going to need networks. Now's the time to get prepared. You need to create a common vision with your folks, and a lot of that might come from this value proposition and then conversations. You want to take and connect as quickly as you can with the folks you know you're going to need, both in the now and the long run. We've talked a lot about some of the opportunities to collaborate and integrate already. Remember, if you're creating common workflows, if you're creating clinical guidelines that help to inform how to care for people in a more efficient manner, that's a win today, that's a win tomorrow. And prioritizing the key issues to address and solve together, again, both the short run, but at the same time, what were those things we were trying to solve 3 months ago before this happened? Let's dust some of those off and see if some of those can be incrementally achieved through this work. And again, executing and formalizing new partnerships to the extent that contracts are needed, making that a part of this. So that is our talk today. Again, we deeply appreciate you all being on. What I'm going to do now is ask that we advance to the Q&A slide, and I'm going to take some of the questions and ask them to our panel of experts. And so the first one, I'm going to ask you, John or Tom, whichever you prefer from HMBR, help us understand, just in a nutshell, closing out here, how unique is this regulatory relief within a historical context? What has really changed for me on the ground today? And what does it mean from the perspective, help me understand, I'm a hospital, I'm a medical group. And just in a short couple of bullets, we're being asked, what really changed and what does it mean for me today?
I'll take part of the quiz, John. I'll take part of it. Tom can take the bulk of it. The part of it is from a historical perspective. In the 45 years I've been in healthcare, 10 clinical and administrative, and 35 as an attorney, I've never seen anything like this. They are not eliminating the laws. What they're saying is we're not going to let the law be a barrier to you moving forward. So it is absolutely a call to action from the federal governments, from the regulatory agencies that we have to live with. Tom?
Yeah, absolutely. This, whether it's the stark waivers themselves were staggering. I mean, just the fact that of an explicit statement around paying more than fair market value, of providing rent relief, things that have been so enculturated within health systems that you just couldn't do before, you're able to do right now because this is a crisis. Obviously, there's things that people could always do, and there's always ways to structure properly arrangements between and among health systems and doctors and other healthcare providers. But those blanket waivers, staggering. The FTCs and DOJs, really coming out front when, I think some people felt kind of in the past sort of targeted, especially physician or networks, sort of targeted by the FTC and Department of Justice. I'm not sure if that was the case, but I think a lot of people did feel a little targeted, to come out with a statement that they realize that this crisis requires collaboration, and pointing out sort of that there's a right way to do it, and to go out of their way, a 7-day review process if you have any doubts about whether you've structured it properly. Again, that's an all hands on deck approach that we just haven't seen before.
Thank you so much. This one's for Andy. I'm gonna put it to you, Andy, because it's from an AMC. We're an AMC health system. Give us 3 to 4 really actionable bullets. How can we very specifically, quote unquote, collaborate with small practice independent physician? I think what folks are saying is, I hear the word collaborate, that sounds great. Give me some specific advice on what are some of the things I can do today with those small practices or independent doctors.
Sure. Without getting too far over my skis, so John and Tom from the legal side step in. Assuming there is a structure already within your AMC, such as an ACO or a CIN or other legal means to distribute funds to independent providers as well, then you're halfway there. Otherwise, creating that type of infrastructure is probably the foremost thing I would do. It's your vehicle to affiliate with docs in a broad array of contracting arrangements. When in that type of arrangement and that kind of relationship with independent docs, you can incent them differently. You can pay them for services, such as we were talking about during this response. You can deploy telehealth and provide them the infrastructure and the IT and the backup that they're unable to capitalize on their own right now. Same with other EHRs, telemonitoring, care management and staffing and centralized services, things that coordinate patient care during this crisis is all good to go at this point. And I think, as you said, it is a call to action, and I think AMC is in a strong position to do a whole lot of that. Even though they are strained now themselves, there is money out there, and this is a long-term strategy as well. So none of it's wasted.
And there were innovative and legal and responsible ways of doing that in the past, but with the waivers and the strongly signaled openness by the FTC and DOJ and an antitrust standpoint to actually go above and beyond, I think if you were ever thinking of doing this in the past, this would be the time to do it.
Thanks, guys. Thank you so much. I want to make sure we get to another one because we're running out of time. This I'm going to give it to Margaret because it's more hospital related. So Margaret, we're in this really strange place, right? You as a hospital CEO and working with the association in California, we were cutting beds. Everywhere was overbedded. We were thinking that we were going to be moving to hospital at home very quickly, which obviously wasn't happening. So there was this constant shrinkage, and it goes without saying that this has flipped. Now everywhere in the country, particularly the hard-hit areas, there's this sprint to increase beds. And there's been a lot of talk about what does the future look like with all these beds we've added? Are we going to pay people to keep beds on standby? A couple of questions for you, Margaret, because you've been doing this for a long time. One is, are people going to have any length of muscle memory around this in terms of, will it last a while and then we'll go back to the old days where we were not so old days where we're just continuing to cut beds and not necessarily maintaining bed capacity? That's one question for you, just in terms of your opinion of how well folks will remember and keep this going. But the other question really is, from a hospital perspective, how do I make this financially viable? How does this change my business plan? If I'm thinking that my community is going to need, quote unquote, stockpiled beds, how do I make that happen? What are the kinds of things I have to keep in mind in order to make that sustainable? So sorry for the complex question. I put a couple together for you, Margaret. You get the tough one.
Well, that's a great question, Alan, because what we know is that hospitals as we're running them today are not sustainable if we don't have volumes. I always use the analogy of if I have a house that has 10 bedrooms and only 5 bedrooms are filled, I can't go to the bank and say, sorry, I'm only going to pay half the mortgage today. So we know that just having beds available with trying to keep them staffed at a minimal level is not sustainable. So what we have to look at are there ways that the community, and this is where I think collaboration comes into play, can the community come together to where we can have emergency beds available, whether it's in a hospital and where we can turn some of our special care beds or same-day surgery beds into acute care beds, ICU beds. We have to have an internal plan, but we also have to figure out, can we look at the community and say, for example, in New York, where the Javits Center is being used as a hospital today, how can we work collaboratively with our public health agencies to have these emergency type settings available? I know during the anthrax crisis, we were able to call and we'd have an emergency hospital set up brought to us as a hospital. So I think we have to look beyond the 4 walls of a hospital to have these beds available. We are still going to have the same message out there. We want the lowest cost hospital with the highest quality because there isn't any money. So we still have the same kind of an environment that we're going to be working in. So lowering our volumes in a hospital isn't a bad thing if we begin to look at how we can utilize our community as a source of emergency beds, number one, but secondly also looking at creatively how can we link together to where we actually begin to maybe use some of our funds available to be able to have the hospital beds filled that they have. So we shouldn't be afraid of lowering the volumes in a hospital. For example, if you have a 200-bed hospital and only 100 beds are available, are being filled on a regular basis, the question is, are there other creative strategies that can be used in a community? For example, if you're in a downtown setting, can you work with your condo agencies to figure out, is there a way that we can set up our physicians in the community to have for our citizens to have access to a healthcare provider through a network where if they can get the care that they need via telephone conference call, Skype, whatever network is set up, they then have access to a healthcare provider. But if they have to come to the hospital, then you're the hospital of choice that is going to be referred to. So I think there's different creative things that we can start to work on that we haven't really had the opportunity in the past to do. So this is the time to take advantage of some of those telehealth funds that are out there available to begin to have your community linked to healthcare providers, and then you as a hospital be the hospital of choice that these patients are being sent to. So that's just an example of how we shouldn't get worried about the fact that we don't have every single bed filled, but begin to creatively think of how we can use our funds for some of the other access points that patients could have.
Thank you, Margaret. And with that, I'm going to close out. I want to be respectful of folks' time. Thank you very much again for joining us. We're going to be sending out to all of you a link to both the PowerPoint and the taped webinar. You'll get a copy of the PDF. We'll do a published Q&A for questions that we didn't answer and the ones we answered here. Get that out to you in a couple of days. Thank you so much again, all of you, for joining. And there is a survey request when you log off of Zoom. If you get a chance to do that, we'd very much appreciate it. Take care, everyone.